I'll start the presentation by sharing my screen, and I hope everyone can now see my screen. So, as this presentation is all about Tickplex and how Tickplex can help healthcare providers in improving or helping with the patient diagnosis, I just want to set the theme for this presentation, which is testing multiple microbes. One of the key features about Tickplex is testing multiple microbes. With that in mind, we should take a step back and understand multiple microbes from different disease standpoints. Now, if you take, for example, periodontal diseases, up to 50% of the global population suffers from this. And the disease has been characterized with with 500 different microbial species. Existence of multiple microbial species in periodontal disease patients increases the risk of cardiovascular diseases by 44%. Moving forward with respiratory diseases, up to 400 million patients worldwide suffer from respiratory diseases, wherein 200 different microbial species can exist. Now, again, multiple microbial infections can increase the risk for diabetes up to 90%. And more concentrating in the niche of this presentation is mosquito-borne diseases. So up to 40% of the global population again suffers from mosquito-borne diseases, and there are multiple reports to indicate symbiosis between between different species of Plasmodium or dengue virus types that leads to immune suppression in patients and also causes severe meningitis. When it comes to tick-borne diseases, while we know the worldwide prevalence of this disease, and it can be said that 2.4 million prevalence worldwide is a gross underestimation, we do not understand the complete microbial spectrum associated with tick-borne diseases, especially the likelihood of multiple microbes happening in these patients. While there are literature to show that ticks are a source of co-infections, and so much so that they can carry 127 different bacterial types. Now, for our study or validation of Tickplex, we selected 3 different species of Borrelia: the Borrelia burgdorferi, Borrelia absili, Borrelia guerini, and then well-known tick-borne co-infections like the Babesia, Bartonella, Brucella, Ehrlichia schiffensis, Rickettsia acari, and the tick-borne encephalitis virus. When you look from overall perspective, the general understanding of co-infection rate among tick-borne disease patients, the range varies from 4% to 60%, and this is a very important range that I will be referring to later in my presentation. But moving forward, and probably what is more interesting about the Borrelia bacteria is its superpower to change from spirochete form to a round form. So what you see over here is an electron microscope image of a Borrelia spirochete structure. And when this Borrelia spirochete structure encounters unfavorable conditions, you have the Borrelia round body. Now, the Borrelia round body differs from the Borrelia persistent Borrelia spirochete form in many aspects. And one of those, and a few aspects are the antigenic property in Borrelia round body is different compared to the spirochete. The Borrelia round body is able to elicit different cytokines and chemokines compared to the spirochetes. More importantly, the round bodies are dormant structures, and they are associated with host immune evasion. There are reports to indicate that Borrelia can revert back from spirochete structures to round body and round body structures to spirochete. So it is an interesting structure, and we were able to isolate these structures for the use of in vitro diagnostics. And we're using a new terminology for these structures, that is the Borrelia persistent species, because they differ a lot from the Borrelia spirochete forms. Now, moving forward, though, when a patient is exposed to a tick-borne infection for a very long time, there's a good chance that the patient will develop a weak immune system, and this gives rise to opportunistic microbes. So, chlamydia species, Coxsackie virus, cytomegalovirus, Epstein-Barr virus, human parvovirus B19, and the Mycoplasma species. And while there is good literature associated with these for tick-borne diseases, these are also the microbes that we included. Now, with so much literature out there showing that multiple microbes do have a clinical relevance in tick-borne disease patients, the big question for us was, do tick-borne disease patients actually respond to these multiple microbes on a common platform like ELISA? So we designed a study wherein we collected 432 patient samples. 80% of them were from different countries in Europe, and 20% of them was from the US. And we included the 20 microbes, the same 20 microbes that we went through just now: the Borrelia spirochete species, Borrelia persistent species, opportunistic microbes, and the tick-borne co-infections. And we used the normal ELISA platform, wherein we measured for each patient and each microbe the IgM and IgG response. Um, while we have this patient group, it is also important to understand the division among these patient group that we have. So the Lyme disease diagnosis, the CDC two-tier system, so that we are all on the same page. Erythema migrans or a bullseye rash is a clear indication for Lyme disease. However, if you're showing flu-like symptoms and the symptoms have been for less than 30 days, you are tested for the Western blot IgM and IgG, and the first tier for that is the enzyme immunoassay. However, if the symptoms have been for more than 30 days, you only get the IgG Western blot, and if the blots are positive, you get the treatment, and the treatment varies from country to country, really, despite the guidelines. So we had patients with fitting different diagnostic criteria. We had patients that had EM rash and were or had an IgM positive blot. Then we had patients with late Lyme disease symptoms and had IgG Western blot. We had CDC negative patient. Now, in most research, CDC negative patients are considered as healthy controls. However, we were curious to really see how these patients were to react to other tick-borne disease microbes. So the CDC negative patients were negative by the CDC criteria, and we have them as a special criteria. Now, we also have the post-treatment Lyme disease syndrome patients. As you already know, these patients were positive for the disease, received treatment, but after a certain period of time, they started seeing symptoms again. In addition to these groups, we also had the immune compromised patient group, and this is where the CD57, low CD57 was seen in these patients, and no T cell response was seen to the Lyme antigens. In addition to that, we had unspecific patients. These patients were not positive for Lyme disease, but they had Lyme disease-like symptoms and were tested for other microbes, like Epstein-Barr virus, like chlamydia species, like mycoplasma. And then finally, we of course had healthy controls or healthy donors for the evaluation of cutoff marks. Coming to the results, on the left-hand side, you can see the IgM response, and on the right-hand side, you can see the IgG response. Right away, you can see that almost 51% patients in IgM and 65% patients in IgG responded to more than one microbe, versus just 9% patients in IgM and 16% patients in IgG that responded to one single microbe. So the difference, the sheer difference between patients responding to a single microbe versus multiple microbes is 4 to 5-fold greater. And this is where the 4 to 60% co-infection rate comes in. You can see that our findings of 51% and 65% are fitting the international norm or international consensus, which is 4 to 60% co-infection rate. But what is more important over here, again, is you see the IgM response on the left and IgG response on the right. You see that patients have different response to just the spirochete species of Borrelia and just the persistent forms of Borrelia. And in IgM especially, you can see that patients are responding more to the persistent forms of Borrelia rather than the spirochete structures of Borrelia. So this is very interesting. But what is more important is that a larger proportion of patient is actually responding to both the spirochete and persistent form of Borrelia. Another important point that I'd like to add over here is that 18% patients in IgM and 22% patients in IgG did not respond to any of the Borrelia species or forms. They responded only to other tick-borne co-infections or opportunistic microbes, which brings me to a conclusion that in the year 2016 in the US alone, 2.9 million tests for tick-borne diseases were ordered. or prescribed, or if that's the right term. But only 17% of those tests were actually for non-Lyme patients or non-Lyme diseases. This percentage obviously needs to go up, and this increases with our understanding of other microbes being associated with Lyme disease, which I will be coming to in this presentation. Now, these are a lot of numbers. Obviously, I do not expect you to go into each one of them, but I have these red boxes to guide you through. And the very first thing we see over here is that the CDC acute patients have a higher response to Borrelia species compared to the IgG in IgM. And then for the CDC late patients, you see a higher response to Borrelia species in IgG compared to IgM. So we have a fitting data visually, so to say. But if you go deeper into the analysis, we see that a larger number of patients are responding to the Borrelia persistent forms in CDC negative patients in IgM and in IgG. So we statistically analyzed this to understand what does this really mean from a clinical standpoint. And we saw 70% of the patients that were negative by the CDC criteria, they responded actually to the persistent forms, which therefore correlates into 3 patients out of every 4 CDC negative patients were positive for Borrelia persistent forms in our study. And going forward, a larger trend in C is seen in post-treatment Lyme disease syndrome patients. So you can see visually, even over here, that about 23 to 35% of the patients are responding to Borrelia spirochete species, whereas 45 to 26% patients are responding to Borrelia persistent forms in IgM. In IgG, that percentage increases to 55, which is the largest over here, versus 39% for Borrelia burgdorferi. So if you were to take 100 post-treatment Lyme disease syndrome patients at random, and that is the statistical test we did, we found that 95 of them would respond to the Borrelia persistent forms over the spirochete structures, which is, again, a very interesting finding. But then we cannot ignore the other microbes that we have, like Bartonella henselae, Chlamydia pneumonia, Epstein-Barr virus, Mycoplasma fermentans, that are standing out in these patients, like the CDC late, the immune compromised patients, and the post-treatment Lyme disease syndrome patients. So what does this mean from a clinical standpoint is something that is always interesting. So, but this is kind of the main key findings of what we're trying to do over here, is that we try to analyze how many patients would respond to just Borrelia out of the 432 patients, and how many of the patients would respond to Borrelia and other microbes. And what you can see over here, especially the black bar, is that it represents patients that have responded both in IgM 61% and in IgG 61%. Patients have responded to the spirochete structures, persistent forms, and other microbes. So Borrelia is again at the center of tick-borne diseases. It is important to diagnose for Borrelia, as you know it. But I think the main take-home message over here is that we cannot ignore other microbes, other tick-borne co-infections, and opportunistic microbes. So one of the other things I'd like to again show over here is the persistent forms, the dotted bar over here. You can see that in IgM, patients are responding more to persistent forms and other microbes than in IgG. So this could represent immune dysfunction also in the patients. So the difference between the patients responding to just Borrelia versus patients responding to Borrelia and multiple microbes is basically 7-fold greater. So if you were to take 100 Lyme disease patients at random, 85% of those patients would suffer from multiple microbes, is the key finding from the Tickplex validation. But obviously, we need to understand the sensitivity and specificity of the Tickplex data. And while I can maybe magnify over here, and so what you see over here is the sensitivity, specificity, positive predictive value, and the negative predictive value for the Borrelia antigens. And we've really segregated and looked into each and every aspect of it. So first, we're looking at IgM separately, IgG separately, and IgM and IgG together. Many diagnostic tests in the market do look at IgM and IgG together. And then on the left-hand side, we're looking at spirochetes, persistent forms, and then spirochetes and persistent forms together. So what we're basically showing over here is that when you add spirochete and persistent forms together, and when you're looking at IgM and IgG responses together, you get the best sensitivity, which is 94%, and the specificity, which is 91%. Uh, but you can see that the sensitivity decreases when you are looking at just one antibody. For example, if you're looking at just IgM, the sensitivity for spirochetes and persistent forms is 64% versus for IgG, it is 88%. So we are showing this chart basically to be transparent in how and why we advocate the use of IgM and IgG together, including spirochetes and persistent forms in the testing and diagnosis of a Lyme disease patient or a suspected Lyme disease patient. Uh, Moving forward to other microbes, we have the lowest sensitivity, so to say, is for Bartonella henselae, and the lowest specificity, so to say, is for Babesia microti. And I point out the lowest, the first, because getting samples for Babesia microti and Bartonella henselae is quite difficult, and that has been a limitation in our study, and that is obviously reflected in this table. But you can see otherwise is that we are showing a sensitivity and specificity that is at par, if not at par, better than other diagnostic tests currently in the market. And obviously, the convenience of testing all the microbes together makes it very, very affordable and convenient for the healthcare providers and the patients. So if I had to conclude, we started with an initial question of what would be the microbial spectrum associated with the disease. We can be sure that it is at least 20 different microbes that are associated with the disease, and the co-infection rate is anywhere from 4 to 60%. But the new information that we have over here is that 85% of the patients that will respond to Borrelia will also respond to these other microbes. And that is where the use of clinical diagnosis needs to change. So why do patients respond to multiple microbes? Because ticks carry multiple microbes, and then long exposure to tick-borne microbes makes the immune system weak. And that is the reason why patients harbor or respond to multiple microbes. Why is this important? So this is important from a differential diagnosis standpoint. Lyme disease is a puzzle piece to a very big puzzle, which is tick-borne diseases. When you're looking at Bartonella henselae or Mycoplasma species, there is research to show that patients with Lyme disease and chronic fatigue syndrome see Bartonella henselae and Mycoplasma species. Chlamydia is infamously associated with arthritis and multiple sclerosis. I've written multiple sclerosis again over here, but that is Epstein-Barr virus. The use of the presence of Epstein-Barr virus increases the chances of developing multiple sclerosis by 90%. And again, there's meta-analysis to show this. And that is why it is important to include multiple microbes in a patient's tick-borne disease diagnosis rather than Lyme diagnosis. So where does this Tickplex validation fit in the history of tick-borne diseases as a whole? Well, in 1982, we had the correlation between the tick and the Lyme disease by Dr. Bugdoferry, and in 2006, the CDC and IDSA guidelines kind of became the status quo. However, in 2016, we had a study by Michael Cook and a colleague, Michael Cook, and he showed that the overall sensitivity for the CDC two-tier system is 62.3%. And in the past 10 years, that is from 2006, this has only increased by 4%. In 2018, we were the first group to actually show different groups of bacteria that are associated with tick-borne disease patients, and how important it is for clinicians, for healthcare providers, and even the common public to understand that tick-borne disease is exceptionally polymicrobial in nature, or multiple microbial in nature. I put this chart over here because there is a good estimation that by 2050, 35% of the global population will be affected by tick-borne diseases. And taking these results into account, we need to do better for the patients. This study is freely available. It is published in Nature Scientific Reports. Here is the title. And the main take-home message of this study is that it is not just Lyme. It is not just Lyme. With that, I bring back my presentation to a full circle, wherein Tickplex helps in multiple microbes, detecting multiple microbes in multiple disease stages. And then now Dr. Armin will speak more about Tickplex Plus, Tickplex Basic. So Tickplex Basic is basically only for Lyme disease. It includes the Borrelia spirochetes species and the persistent forms, whereas Plus is for core infections and Borrelia. So we can have the question and answers at the end. I think we continue with Dr. Armin's presentation.
Yes. Hello, everybody. Thank you so much for your attendance. Very important message is in Europe, we will get, or we have a new law in 2 years. It's just allowed for laboratories in routine analysis to do CE certified testing. So this is a very important message. So everybody needs to check own methods, if it's home-brewed or not home-brewed. So the Tickplex belongs to the CE certified testings. This is correct. If you maybe confirm that.
Yes, that is correct. Tickplex has always been CE certified.
So we fulfill the criteria to get the accreditation and the allowance to do it for whole Europe and the rest of the world. My name is Armin. I'm a laboratory doctor and medical doctor, but I specialized more for Lyme disease because I see absolute need to work in this field. And you see here in the slide principles of immune defense mechanism. These are all indirect testings. It's not to prove the pathogen directly. So we use some serum also in the Tickplex, or we use some cells, lymphocytes or whatever, or macrophages. And you see in every immune defense mechanism, there's an invader, in this case Borrelia. And the macrophages, they detect the invaders. And then the macrophages play the first role to present these invaders, Borrelia, to natural killer cells, in this case the CD57 natural killer cells. And by that mechanism, Borrelia can get directly destroyed. On the other side, you know that Borrelia is not interested in getting destroyed by macrophages or other cellular or humoral immune defense mechanism. Borrelia evades that by persistent forms. We come later to that. Kunal talked already about that. On the other side, it's very important also to know that the macrophages present this pathogen, in this case again Borrelia, to Th0 cell, and the Th0 cell is splitting into Th1 cell and Th2 cells. The Th1 cells represents the T cellular immune system. Therefore, we are doing ELISpot testing, which is some kind of interferon gamma release assay. And by this T cellular immune defense mechanism, Borrelia can be destroyed. But the question again, if Borrelia evades that destruction, what happens with Borrelia? Maybe it persists intracellular, wherever. On the other side, we all know about the Th2 system reaction, and this is a classical pathway of antibody production. And by the antibody production, the macrophages destroy the antigen-antibody complexes, including Borrelia. And in the end, you all know we have the histamine release, and I did a talk yesterday in London about that. And the histamine intolerance is, or histamine release is the reason for histamine intolerances of patients in the gut, and maybe they have leaky gut or whatever. On the other side, in every infection, you have a histamine release. It's not just for Lyme disease. So this is a natural immune defense mechanism, which is our nature and which helps us to destroy pathogens. The next slide shows you about the aims of these immune competent cells, the CD57 and K cells, they reflect a chronic active process, the destruction of antigen antibody complexes. The Th1 system is reflected by the T cellular immune system. It reflects current activity, and the Th2 system is represented by antibodies, and in this case, Tickplex is coming into that. It's a B cellular immune response by IgG, IgM, and this test can be done to different kinds of pathogens. It's not just for Lyme disease. I want to come now to the B cellular immune system, the production of IgG, IgM antibodies. You all know IgM antibodies are a very huge molecule. They have 5 binding arms with heavy chains and light chains. And it's possible in the very early or fresh infection that you can bind 5 pathogens in the 5 different arms of this really big protein molecule. The IgM it appears in, as I mentioned, in early infections, very early infections. It's a systemic marker, very important to know about that. It's not produced in locally or localized infections. It's a systemic infection in the very fresh phase. And the IgM antibodies, they cannot pass the human placenta. Just IgG is able to pass the placenta. So IgM antibody also in Tickplex test is very helpful for babies up to an age 6 months. Then they lose this and they produce IgM antibodies themselves, and they lose the protection by maybe mother IgG. And the IgM has a very useful diagnostic feature. It indicates a recent infection, or in neonatate serum, it indicates an intrauterine infection. So if you're not sure if a baby is infected, maybe you can check also by Tickplex or maybe other antibody testings for IgM. Not IgG. IgG will not help you in this case. Immune globulin G, this is where we all know about it. It's a former infection. But IgG has 4 different subclasses, and you see the percentages. It's 66% IgG1 and 23% IgG2, 7% just IgG3, and IgG4, it's a minor concentration in our blood, it's 4%. And you see that IgG2 is also not able to cross the placenta. And very important message is that in every immune reaction with IgG, immune globulin G, to destroy a pathogen, you need complement activation. And you know that some kind of Borrelia subspecies can block the activation of C3 and C4. So you have more activated, and it's not used in this block. So the antibodies cannot work. So it's a frustrated process of production for IgG, which is not helpful to destroy pathogens. And to me, very important is the half-life time of all of these immune globulins, IgG, IgA, IgM, IgD, IgE. The half-life time of IgG you can find for the different subclasses. It's 7 days to 21 days. What is a half-life time? I come to that again. Immune globulin G has also 2 binding arms. It's not produced in the early phase of an infection, and it's coating the surfaces by opsonation, and also it can do an recognition and ingestion by the phagocytic immune cells, and then it can eliminate to the pathogen again itself. But again, the question, if complement is not there, it's blocked, and maybe Borrelia is going into persistiforms because you treat with antibiotics, then the IgG cannot work, and IgG is not produced. So you will not find IgG. It's under the detection level, we name it, although it's maybe there in a little concentration. IgG activates always the classical pathway of a complement system. I mentioned that, and it can also bind and neutralize toxins, and it plays also a role in intracellular mediated proteolysis and also in the cell-mediated cytotoxicity. And IgG is also associated with type 1 and type 3 hypersensitivity reactions. So, you know, food intolerances, IgG, and we can measure that for some food detections. But I go back now. What's very important that in chronic infections, you find, interestingly, subclass deficiencies, especially IgG immunoglobulin 1 and immunoglobulin 3. And you can measure that. You can determine IgG subclass deficiencies. Then we name it, it's a IgG subclass deficiency syndrome, an acquired IgG subclass deficiency syndrome by bacterial infection. Back to the half-life times. Why is it so important? Because we can not detect the immunoglobulins forever, because half-life time, what does it mean? It means our body eliminates 50% in that time. So within 5 days, we eliminate the IgM, 50% of that. The next 5 days, we eliminate again 50% of IgM concentration from our blood. For IgA, it's 14 days, and IgG, immunoglobulin G, you know, it's 21 days, 3 weeks. So that means to come from 100% to maybe 0%, you need 6 to 8 weeks, 2 to 3 months to get negative IgG if the pathogen is not still active in your body. And for IgM, you can say, okay, it's up to 3-4 weeks maybe, but it depends on the concentration. Everybody is producing individual concentration. You cannot generate a rule by that. You know, it's so individualized, all of these processes. Now I come to the laboratory. You all know that we have a major trap with false negative antibodies and chronic Lyme disease. And Lyme disease is or was not always detectable by antibody tests. We don't have a standardization for antibody tests, and we have sensitivity problems of the former old-fashioned ELISA technique. And therefore, Tickplex came into that, and they are the first ELISA which is very, very sensitive, also in chronic infections and against these persister forms, which closes the gap now to undetected antibody situation, IgG, IgM, in chronic persistent Lyme disease. The specificity means a false positive result, and sensitivity is a false negative result. And what you can see, the antibodies were never a problem in all of the paperwork we did in 1993 until 2000. And you mentioned already Professor Puri and Michael Cook. They did this wonderful paper in 2016. And astonishingly, the sensitivity, all of you know, I think, meanwhile, for chronic Lyme disease, it's not for the acute phase, it's not for Bull's-eye rashes, it's not for Bell's palsy, it's not for acute myocarditis. This is just for chronic. And the problem is always the case definition, how you do a definition of chronic Lyme disease. But if we accept chronic Lyme disease, we come to a conclusion that just in 40% or 32% or up to 42% the ELISA is positive in chronic Lyme. And this is the really interesting paper from Professor Puri. He did it in 2016, as Kunal mentioned, and you see that there's a lack of standardization. Also, C6 peptide ELISA is frustrating process to do that. Also, we have huge sensitivity problems with a 2-tier system nowadays. So also CDC, you maybe heard about that, is leaving that way, frustrated now more and more about this lack of sensitivity. The next is a slide I did about comparing different kinds of Lyme testing for Borrelia burgdorferi. Maybe I need to mention that Lyme disease, it's a clinical diagnosis done by clinicians, and laboratory tests are supportive tools in that. As you do also in other clinical decisions, you always need to get the clinical picture and not just to do a laboratory test. And Kunal, you showed already the predictive value of Tickplex, which is really a high predictive value, but you should not use Tickplex as a predictive marker. You should first do a clinical diagnosis or clinical suspicion for the clinical diagnosis of Lyme disease, and then you do the laboratory testing confirming your suspicion, and then you have a very high predictive value what you're doing in medicine. The ELISA, to make it short, has the old-fashioned ELISA. I think it's an ancient method. We don't need it in the future. It has a very poor sensitivity and poor specificity. CD57 cells, they have maybe a poor specificity, but they have very high sensitivity for chronic infections, chronic bacterial infections, I need to say. The C6 ELISA is not useful. I do a lot of C6 ELISAs, which are, you can like rolling the dice with it. It's not so interesting. The Seraspot, I did a trial some years ago with microarray, but the Seraspot has the same problem. It's not sensitive enough, but it's high specific if you find antibodies. These are Borrelia antibodies in 99%, but it's not sensitive enough. The Tickplex, now I think it's really a revolution in this field, because we closed the gap by a high sensitivity for round bodies. No other test in the world is looking for that. The Western blot is also poor sensitivity, as I showed you before. The PCR in blood is needs modification. Maybe in the future it could be an idea to do some PCR, but I like more the PCR from tissues, from biopsies, but not from blood. Borrelia burgdorferi doesn't like the blood so pretty much. Maybe it's sometimes in the blood during the summer flu phase, in the first phase of infection, but it likes more the tissue. Afzelia likes more the skin, Garenia likes more the nerve system, and Sensostrictio likes more the joints and the tendons and the muscles. The ELISpot is a high sensitive method and high specific method. And you know the Borrelia culture is no longer available because there were some contamination problems. And what I know, the problem is not solved till nowadays. It's I think they're still working on it. Yeah, the problem, what I see, and we saw during this project with these round bodies are also named pleomorphic forms, or maybe you name them persister forms. In the Tickplex, it's named round body antibodies. And you know, also we have the biofilm problems of Borrelia burgdorferi. I hope in the future, Kunal will, some companies would develop a biofilm testings that we can put some monoclonal antibodies against that, or some idea about that, because I'm sure that we have huge biofilm problems in chronic infected patients with Borrelia, chlamydia, mycoplasma, Yersinia, and other infections. Now I want to show you a Tickplex result. This is what I see in my daily work. This is a Tickplex basic. This is a very cheap version. So if money is an issue, I always would recommend not to do Western blot, not to do ELISA, not to do immunoblots. Please do the Tickplex basic, because if it's chronic, you include the pleomorphic forms, which is the key for the future. I'm absolutely convinced of that. And in this case, you don't find any antibodies against the pleomorph, the spirochetal form. IgG, IgM, it's negative 0.620. It's the index, and 0.470 for the IgM. But you find IgG round body antibodies, and this confirmation what Kunal said to you. So maybe it's also difficult for you clinicians how to treat persisters. Is it easy to treat? How can you treat this? What about the biofilms around the persisters? Is it possible to treat persister forms? Maybe we cannot treat persister forms because they persist and they are sleeping, they are snoring. We have the same in EBV infections as an example. They also need not to be active. I want to show you another case of a patient with a CD3 cells and CD7 cells. It's now slide 18. What you can see here, the CD3 plus cells are so important. They have here in this case 984 per microliter, a tendency to get very low. That means we find a lot of patients with virus infections. They have suppressed CD3 plus cells. And what we see now, what Kunal already said to you in multiple sclerosis, I got a new study some weeks ago. It's more and more evident that EBV is doing multiple sclerosis, maybe together with Borrelia burgdorferi, who knows. On the other side, it's clear evidence for that. And the natural killer cells, you see here, the CD57 cells, they are 10 per microliter. This is a very chronic bacterial infection. That's for sure with pain and with musculoskeletal symptoms. 10 is nearly nothing. So natural killer cell system is breaking down. These patients need also natural killer cell therapies. You see the CD56 subpopulation, which is going down also in virus infections. It's just 76 per microliter. So this looks like an HIV patient with a bad bacterial infection. And corresponding to that, you see the Tickplex. Tickplex shows you in that patient IgG pleomorphic forms, it's positive, and IgM pleomorphic forms, it's positive, and also the round bodies, the persister forms, are weak positive IgG, but they're clearly positive for the round bodies, persister forms for IgM. So you have parts of this complex infection, parts of it are these spirochetal forms of Borrelia, and parts of it are the persister forms around bodies. So this is a patient in between with persisters, but also extracellular, intracellular spirochetal forms. The same patient also expressed in his results a weak positive Babesia IgM antibodies, and also for Bartonella weak positive. The same for Bartonella henselae, which is associated with cat scratches, also not just tick bites. And the rickettsia was negative in this patient, so that you cannot say every test is positive. In the same patient, we had also Rickettsia acari IgM weak positive. We had also the parvovirus in the next slide, you can see positive, and a clearly positive immune answer for Mycoplasma IgM. So this is really IgM dominant patient with no seroconversion in this other infections or opportunistic infections, no IgG production. That seems to be a persistent patient with different infections, but not rickettsia in this case. So Tickplex gives you a lot of information about that, which infections are active or not active in the patient. It's really a good test for IgM and also to find out about the persister forms. The last patient I want to show you, it's patient number 3. So you can see here a weak positive IgG for the spirochetal form of Borrelia burgdorferi. You can also see here the IgM is negative for the spirochetal form. You can find weak positive Babesia microti IgG. You find a clearly positive Bartonella henselae IgG. No, not IgM is positive. You found, or we found Ehrlichia schaffensis IgG positive. We found Rickettsia IgG positive, not IgM positive. So also Coxsackie virus IgG positive, subtype A16. We found also A16 IgM weak positive. So there's something wrong with Coxsackie virus, I think so, because IgM is a little produced in this patient, for the other pathogens not. Maybe Coxsackie virus is a big issue in this patient. Epstein-Barr virus, EBV, is also positive in the IgG and weak positive in the IgM. And for parvovirus, it was positive in the IgG. So you see, it's like a mosaic. We bring a mosaic together, but we need clearly which direction also treatments should aim. What do you do now with this patient with possible viruses, with possible bacterial infection? But I can confirm completely, there's not one patient with just one infection. I see in many patients multiple infections. That's for sure, that's proven. The basic diagnostic test for chronic Lyme disease, in my opinion, should aim the round bodies by Tickplex basic, because we reach really really high sensitivity. I think sensitivity is around 95%. Specificity should be around 99%. So it's not 100% specific, but nearly 100% specific. We could do the ELISpot test for the current activity. Sensitivity is not such a good one like the Tickplex basic. It's around 84%, but specificity is around 82 to 100%, depending on the paperwork it's based on. The CD57 cells have a disadvantage. They're not specific for Lyme disease, but they are low in bacterial infections. They give us a good impression about that. Sensitivity is also not such overwhelming, but it's 70%, and this is also a really helpful tool. And so thank you very much for that.